at Lokmanya Tilak Municipal Medical College and General Hospital, Sion, where over the years she has done various roles and with a teaching experience of 26 years. She is a member of Indian Academy of Pediatrics, Society of Developmental and Behavioral Pediatrics. So I'd like to call upon none other than Dr.MonaGajre ma'am to enlighten us on today's topic of ADHD and diagnostic tools. Good evening, ma'am.
Thank you very much for that kind introduction. So today's session is on ADHD, on the types of ADHD and the tools that one can use in office practice for diagnosis of ADHD. So ADHD, as we know, is the most common neurodevelopmental disorder in childhood. In fact, the prevalence is almost 5 to 10% in the community, which is huge, really. Most of it is underdiagnosed because the awareness is not much. But nowadays, post-COVID, the awareness is increasing in ADHD, and the cases also are increasing of ADHD. ADHD, as it stands, is the full form is attention deficit hyperactive disorder, and the symptoms include either inattention, hyperactivity, or impulsivity. So what does inattention mean? Inattention, when we say, what comes to our mind is the ability not to focus on a task. What does impulsivity mean? Impulsivity means acting hastily without giving it a thought or acting on your emotions. And hyperactivity is excess movement which is not suitable in that particular setting or the particular environment. So it's also like children always, or it's like the child is motor driven or something like that. So these are the components of ADHD as a complex. Now we'll see what are the types of ADHD. So there are essentially 3 types of ADHD. One is the hyperactive type, and it is the hyperactive and impulsive type. So HI, ADHD HI as it's known as. And in this, the hyperactivity as well as impulsivity is very prominent. And this is very commonly seen in preschooler age group. So by preschoolers, I mean children aged 4 to 6 years of age. Then the second common presentation is ADD. Okay, so in this, the H is not present. That is, there is no hyperactivity. It is more of inattention is the presenting feature. It is commonly seen in girls, and usually it goes unnoticed. And most of these children that I have seen is because they are so quiet in the classroom and they're in their own world. They're dreamy, they're forgetful. The teachers are not bothered about, much concerned about these children unless their academic grades start dropping. So that is the commonest way that they present to you and me in the clinic, that the grades are dropping, and then the parent will, on coaxing, and when you interview the child or when you send certain questionnaires to the school, you will realize that this child is usually prefers to sit next to the window, looking out of the window in her own world, incomplete notebooks, etc. So this is the second presentation, the ADD or inattentive type. And the commonest presentation is a combination of both. That is the hyperactivity part and the inattention part. And it is known as ADHD-C or the combined presentation. And this is the commonest form that we see in clinical practice. So ADHD-C or the combined form is the commonest presentation, followed by the inattentive form, followed by the HI form. So the prevalence of ADHD in the community, in Indian community, there are very few studies in literature to know what is the prevalence in the community. As I said in the opening remarks, that about 5 to 10% is what is the prevalence in as per the US estimate. Nowadays, with social media excessive use and mobile excessive use, we see a lot of uh, children coming to us who are referred for symptoms of ADHD like. So it is very important to distinguish whether it is because of the environmental factor, in this case, whether it is because of excessive mobile usage, or whether it is an intrinsic ADHD neurobiological condition. So to know what is the prevalence of ADHD in the community, we undertook a study wherein we screened about 1,300 school-age children. And these children were in two settings. One was the urban setting in Mumbai, and one was a semi-urban setting at the suburbs of Mumbai. Because we wanted to look at two different environmental settings to look at the prevalence of ADHD. So we found that the prevalence in the community in both settings was about 8%, which is similar to what literature tells us, which is similar to the Western literature. And of course, as we discussed previously in the previous two sessions, that neurodevelopmental condition never comes alone. It always carries with it a friend along. Okay, so the friend in this case is a comorbidity, and the prevalence of comorbidities, we saw that with ADHD was almost as high as about 70% in the community. So this is a study that we did to look at various therapies for children with ADHD. What is the role of parents in ADHD? Now, coming briefly to the causes of ADHD, it could be structural, neurobiological, genetics, or environment. So in structural, you see that we have the frontal cortex, which is the CEO, the prefrontal area, which is the CEO of the brain, which kind of controls our impulses and is the seat for executive functions, which we'll discuss in the later slides. And so we see that when there were studies done of structural MRIs on these children, they found that in children with ADHD, the brain size was smaller. The left brain was much smaller or equal to in size of the right side of the brain, right? So that was what was found. Also, the limbic system or the subcortical regions were also smaller in size. Now coming to the genetics, we will see in the next slides how the genetics influences the cause for ADHD, and the environment, as I discussed just now, that children, certain stressors. So, it could be maybe the child, there has been an adverse event in the family, there has been a death or a close family member, and post that, as a post-traumatic reaction from the child could have overactivity and display some symptoms of ADHD-like, or excessive use of media or mobile, and then suddenly the mobile is taken away, and then the child could have these symptoms of ADHD. Lack of sleep is a very big reason for ADHD-like symptoms. So coming to the neurobiology, we know that there is an acronym known as DOSE. So DOSE stands for, and this acronym is for the happy hormones which exist in our body. So these hormones should be maintained, these four hormones should be maintained at an optimal level for our optimum mood and alertness or an attention. And what are these four hormones? So D stands for dopamine, O stands for oxytocin, S stands for serotonin, and E stands for epinephrine. So amongst that, dopamine and epinephrine, or D and E, are crucial for attention too. And whenever there is some imbalance in the body because of this, then attention of ADHD like symptoms can occur, right? So why is dopamine necessary? Dopamine is necessary for the working memory, the behavior, and motivation, right? Working memory is something like, so when I'm reading something, or when you are reading something, supposing the line is, my attention keeps fluctuating. So when you are reading each word by word, you have to keep in your memory the previous word which you have read, and also the current word, and then make a understanding of what the entire sentence meant. Okay, for you to reproduce or understand the sentence such that you can either reproduce it in the written format or in the oral format. So that is called as working memory. So as you're reading the word, in the brain, in the hippocampus, there are smaller units of memory which are happening for each word. And to keep them all together, like say you are, the other example, if you are stringing a string of pearls. So one pearl by pearl, you're putting it in a string. All the pearls have to be set together for a string to form, or a necklace of pearls to form. So that is working memory, essentially keeping all the units together such that you can make some sense of those units. And for that, dopamine is a very crucial hormone. Dopamine also modulates your behavior and motivation. So in a lot of children, we see that the parents complain and say isko padhai mein interest nahi hai, khelne mein interest nahi hai, and सिर्फ mobile देखना है दिन भर. So that motivation which is there, or the drive as we call it, is because of dopamine. So, and now coming to norepinephrine, it is essential for sustained attention alertness. So what do I mean by sustained attention? Sustained attention is being focused on a task which is not very stimulating, or say it is boring or routine in nature. So if you see nowadays, most of the young generation, or even our generation for that matter, they want novelty. Every time they're seeking novelty, and they want new things, or you can sustain attention only if it is a novel item. So in sustaining attention and alertness, it is, even if the task is boring and repetitive, the attention has to be sustained till the activity is continued. And also norepinephrine helps in staying focused. So if I'm reading or I'm talking to you, there's a background sound going on, but I have to ensure that I'm focused on what I'm saying and what I'm reading, and try to ignore the background environmental stimulus. So all that is possible because of norepinephrine. The reason that we are discussing this today is the treatment which is there in ADHD is related to increasing these hormones in the body, right? So now coming to, let us see how the brain actually develops. So we know that myelination happens from caudal to cephalodirection, that is from back to the front. It happens from inside to outside, right? And that is how myelination happens, and that is how development happens, really, right? Now, the red and the yellow parts of the brain are less mature in the slide, and the purple and the blue are the more matured parts of the brain. So by maturing, we mean that the myelination is complete. So this is what a 5-year-old brain will look like. When you look at a 10-year-old, you see that, yes, of course, the blue areas are there and purple are coming up, but more or less, it's quite similar to a 5-year-old. And that is why do these children appear physically very well, quite developed compared to a 5-year-old. A 12-year-old will appear more physically well developed than a 5-year-old. They behave in a very impulsive and childlike manner. And that is because of this area, okay? The dorsolateral prefrontal cortex, which is so important, or which is known as the CEO of the brain, which is essential for controlling the executive functions. Now look at what happens in a teenager's brain. the maturity is happening, the purple areas are getting lit up, but also the prefrontal cortex, which is the most important part, is still getting myelinated. And this is teen brain, so essentially like a 15 or an 18-year-old brain. All right. And by a 20-year-old brain, you would see these are all neurotypical brains. You see that the purple myelination is happening better, right? Now, why the harping? Why am I, so much harping on the prefrontal cortex? Because the prefrontal cortex is the crucial area that one must know of and be aware, because it is this controls the impulses, the behavior, the motivation of the child, and it is important in the executive functions. So what are the executive functions? There are about 7 or 10 executive function. What is the most important one is, as we saw, this the sustained attention, the alertness, the working memory, the behavior, motivation. These are all essential executive functions which are related to the maturation of the prefrontal cortex. And this may be an issue in children with ADHD where the myelination doesn't take place and it is still the area is getting myelinated. So, I would typically tell the parent that we have to handhold the child with behavioral therapy, medications, and in 20-year-old, this is what the myelination happens. But in our children, it may be up to the age of 25 that the myelination may get fully completed. Now, coming to the prevalence of parental ADHD, as I said, that sometimes, my colleagues always comment that ADHD is very easy to diagnose in the heavy OPD. And the reason why is that even your receptionist will pick up that the child is ADHD, because she'll come in and she'll tell you, डॉक्टर साहब ये एक बच्चा बहुत बाहर उधम मचा रहा है, इधर चढ़ रहा है, उधर चढ़ रहा है, बेल बजा रहा है, अब जल्दी से उसको देख लीजिए. So those are in your face or the severe versions of ADHD, but the mild and moderate definitely need questionnaires and a little more structured interviews where one needs to come to a diagnosis. So we did a study again to look at what are the genetics of ADHD. And we found that in parents, so if a child had ADHD, either of the parent having an ADHD, the percentage was almost 18 to 20%, right? And the interesting thing, the other thing that we found, that ADHD-C or the combined type of ADHD, as I said previously, is more common. And if there is a child with a combined ADHD, then the chances are that the father would be having an ADHD which was ignored in his childhood, right? And as I said, the inattentive type of ADHD in males is less. So if you have an ADHD-I or an inattentive type, then the likelihood, whether it is a boy or a girl, it doesn't matter. Though, as I said previously, it is more common in females. The likelihood that the ADHD would be present is more in females. So in mothers, if there is a child with inattentive type of ADHD, the likelihood that one of the parent having ADHD would usually be a mother. Now, why this is important to us? So the important thing to us is that now the key of ADHD is, in addition to medicines, I always say that medicine are stopgap arrangements till we wait out till the myelination, understanding how to control his impulses, because the most of the complication or the consequences of the behavior is because of the impulsivity. As the brain matures, the child becomes more aware of his reactions and his actions, and we are able to train him to modulate them, because that is the best part. So that is what we call as a didactic behavioral therapy or cognitive behavioral therapy. And to have the child do a cognitive behavioral therapy and a program to run cognitive behavioral therapy along with medicines, it is very important to know the parental milieu or the environment that the child exists. Okay, As I always say, that behavior is a consequence of the child, the host, as well as the environment. I mean, this has been taught to us even in long term back in third MBBS during our PSM lectures, right? So the environment becomes very important. And if you have either a parent of ADHD who's prone to anger outbursts, temper tantrums, then you need to not only do the CBT or behavioral therapy for the child, but also sometimes for the parents too. So it is almost like a family therapy, and the outcomes majorly depend upon knowing what is the family, whether there is a parental ADHD existing. The important part of ADHD, and now we are seeing this increasingly, is that ADHD persists into adulthood in almost 50 to 80% of the cases. I would say around 50% of the cases for sure. So it is important to know that they either the child learns mechanisms as they grow out, how to control, how to manage his ADHD, and does not fall to the consequences, the bad consequences of ADHD in adult. So what does ADHD mimic, or how does ADHD can be a mimic of these conditions? One is, of course, global developmental delay. And we've seen this many times, that a child who's cognitively challenged can present, comes to the OPD and he's running around the place and, generally being very overactive. So a developmental delay could be a mimic for ADHD. The second is autism. And that is because autism and ADHD is quite common as a comorbid condition. In autism, ADHD is quite common, almost to a tune of 30 to 35% of the cases. And this is primarily, it's been my observation, the reason for this is because of sensory processing problems. So maybe the child has tactile, vestibular, or proprioceptive seeking behaviors. And so the child is moving around, rocking himself, etc., or flapping, and because of his sensory issues. So once with therapy, once the sensory issues are sorted, you will see that the overactivity and the ADHD also decreases remarkably. The third is that if the child has any sensory issues like hearing or vision related difficulties, again, sensory processing disorders, which I said, vestibular seeking, proprioceptive seeking, that can present as ADHD. Anxiety itself. So the child could be anxious, the child is anxious, and if has a media addiction, will kind of procrastinate things, will delay things, and that can lead to a lot of anxiety building up, and which can present as ADHD. And in fact, these conditions, externalizing kind of conditions and anxiety, is seen more common in younger children and versus the older children, where they have more internalizing issues. Language delays, sleep issues, sleep deprivation issues, environmental challenges, they can all present as ADHD. So you see that the whole list of conditions which can mimic ADHD, and so the history is extremely important to differentiate whether these are ADHD-like symptoms or intrinsic ADHD. So the presentation of ADHD across lifespans, in preschool age, that is between 4 to 6 years, they present with behavioral problems. So usually it will be that the preschool teacher will come, or they say the parent may come to you saying that, he's very difficult to manage. I cannot take him out to any social situations, or the teacher complains that he doesn't sit in one corner. So that is a common complaints that they come in, that अभी एक 2-3 महीने हो गए स्कूल के लिए, पर बच्चा बैठता नहीं है स्कूल में. So this kid will be moving out of the classroom, or peeping in other classrooms, and this kind of pattern in behavior may be seen. In school age children, they present behavioral problems with academic issues and social difficulties. So because they are so impulsive, they do not follow the rules of the game. So in the rules of the game, supposedly they're playing cricket, agar out ho gaya to uska chance नहीं है तो दूसरे को बैट देना, so they will just throw their bat down and say अभी मुझे नहीं खेलना या मुझे bowling ही करना है. So these can cause social difficulties in peers of their age group. So these children typically get along very well with older children or younger children, because they are, if you see a typical ADHD kid, they are very social. They're like a social butterfly, because they're very short attention spans. They keep on flitting and they have no inhibition. So they will go and approach total strangers and chat with them, etc. So they're almost like a sunshine kind of a kid. So the adults seek out these children. They like to socialize with them, but they have social difficulties with peers. So that is one more thing which we needs to ask when you're asking history, कि खेलता है क्या, अपनी उम्र के बच्चों के साथ खेलता है या बड़ों के साथ खेलता है या छोटों के साथ खेलता है. Then they will say नहीं, अपनी उम्र के बच्चों के साथ इसका तो हमेशा झगड़ा होता है, बट बड़े बच्चों के साथ रहता है या छोटे बच्चे उसको बहुत पसंद है. And it can come also with academic challenges, because if the attention is getting hampered, then obviously the child is not writing the homework, is not able to follow what is going on in the classroom, and academics takes a big hit. In adolescence, it can cause self-esteem issues, because we know that as in children, the main occupation is schooling. So if schooling is hampered and there are these repeated red marks and cancellations or remarks in the mark sheet, then the child's self-esteem can get hampered, and they can land up with comorbidities in the form of anxiety or depression. As they enter adulthood, if it is not recognized and treated, then the self-esteem can lead to employment issues, because again, the attention and impulsivity may persist. And so they, join jobs for 3 months or few years, then escape, they look for another job, and so they can have employment issues later. They can turn to substance abuse later, or alcohol abuse, or cigarette smoking. They have, as they grow, they have difficulties in maintaining relationships. So marriage issues, etc., can come. So coming on to certain tools that one can use for screening of ADHD. One is the very much used tool, which is the Vanderbilt tool. And you have two components in the Vanderbilt tool. This tool is available freely on the internet. If you were to Google it and just put Vanderbilt questionnaire, it will come down as a questionnaire which can be printed out, or it can be sent by email to the parents to be filled. So the VADPRS, so it stands for Vanderbilt Parent Rating Scale. Okay, so this is for parents, and VADTRS is for teachers. So both components are freely available, the questionnaire as well as the primary questionnaire, as well as the follow-up questionnaire and the scoring system for both. Then we have our very own Indian tool, the Incline tool for ADHD. This is based on both these tools are based on the DSM criteria, DSM-4 criteria. And then WHO has come up with an adult ADHD self-report scale, which is again freely available on the net. It contains questions which has to be filled by the adolescent. And because these tools are for children less than 12 to 14 years of age. So beyond that, we need the adult ADHD self-report scale. Now, these are all screening tools, and the final diagnosis for ADHD, there are no biological markers, no blood markers, no neuroradiological markers for neurodevelopmental disorders. Though neuroradiological things like fMRI or structural MRI or PET, etc., are more for research use rather than in clinical practice. So diagnosis of developmental condition is almost always a combination of history, observation, and the diagnosis is based on the DSM-5 criteria. So DSM-5 criteria for ADHD is the diagnostic tool for the diagnosis for ADHD. Now, briefly, before we go on to the tools, how does ADHD present in girls? And the reason that why I talk about this is ADHD in girls is a very, very ignored brushed under the carpet kind of a thing. All right. And ADHD does exist. And this has been my experience also. And a lot of literature reviews, you will find that the ratios for ADHD is given that it is a male preponderance. Okay. So it is more common in males versus females uh, is what the literature review suggests. However, it has been my understanding that ADHD is not picked up in girls primarily either because they appear forgetful or they appear withdrawn. They are in their own world, and so it is very easy for you know uh, parents or teachers to ignore them, right? And they appear distracted. So and or they can appear as hyper talkative or exaggerated emotional response. This is almost the key thing that I see in all the children with ADHD, and more so in a girl child with ADHD or ADD, whether she is inattentive or whether she's has a combined type. These exaggerated emotional responses is a very, very common finding. I recently saw a preschooler who was referred to me. The oldest child, they are both are twins, and one child has autism, and the second twin, the second is this girl child. She's about 5 years of age. Yeah. So she was referred because she answered back to the teacher, and she's been repeatedly being defiant and opposition. She's showing oppositionality kind of a traits, and that is why the referral was there. And they've been working with this child for with in terms of therapy for almost 6 months. And she was when she walked in the room, she's a brilliant girl, but she she displayed almost all these symptoms: the hyperactivity part, the hyper talkative, and exaggerated emotional responses. So the parents will almost say that it is difficult to manage her in terms of you do not know which uh, uh, stimuli will cause this exaggerated response, and she would have temper tantrums or she will cry, etc. But in a given situation, the same stimulus may not evoke that kind of a response. Now, whether she has a personality problem, like a borderline personality disorder, she will eventually evolve to, or whether it is ADHD kind of symptoms, is a little difficult to come right to a diagnosis, and she's still under observation with me for that. So that is why ADHD in girls is quite challenging to diagnose, but also interesting because the response to treatment is also good. Also, I believe that to treat these children, this girl child with ADHD with medications or CBT, it when they develop, when they grow up to be of marriageable age and they marry, then and they have families, they have a better understanding of themselves. And if there is a genetic component to it and they have a child with ADHD, they're able to manage them much better. Again, as I said, for preschooler, it is quite challenging to diagnose between the ages of 4 to 6 years, because primarily between 4 to 6 years of age, the children also, are quite boisterous and they're quite noisy, and they like to play. So when does one call them that this is neurotypical behavior versus borderline cases versus in your face ADHD? So that being pediatricians, we are uniquely positioned to arrive to that conclusion, primarily because we see a lot of children of that particular age group, or children with varying age groups. So we are able to define that this activity seems a little more abnormal, or it is not of what you would expect to be in the normal range. The other person who's specifically positioned to have this observation are school teachers, because they generally teach and see a lot of children over their years of experience. Or even in the same class, they would have 40 a classroom of 40 children, and when this one child does not follow command or disobeys, or is too mobile in the classroom, they're able to identify or pick this up, that this seems to be an issue with this particular child. So as I said, in preschool age group, they usually present with overactivity, or they will play incomplete. The play is incomplete. So thoda sa khelenge, coloring करेंगे, फिर उठेंगे, फिर जाके ring ball के साथ खेलेंगे, and that kind of a thing. And the parent will say doesn't listen, and that is why the mimic for autism is there in these children. So they will not. I've seen like 4-year-old, 5-year-old who will just come with just doesn't listen. So it is whether the listening is because they cannot hear, or because there is the component of autism, or because of ADHD. So once we are able to decipher that based on the history and the observation, I had a similar child who was being labeled as autism and going to therapies, but ultimately this child was the ADHD child. And once we gave him medicines and with behavioral therapy, it was like, the autism was never there, which was obviously the autism was never there. It was the ADHD which was mimicking as, or the autism which was mimicking as ADHD. So they have difficulty waiting for turn. And this is very typical, the noisy emotional outbursts, the repeated complaints from the teacher and not included in peer because of the empathy. They just don't get included in peer play. They are more prone to accidents. So I had again one child, I think he was a 6-year-old, who came with the parents came with academic problems. Primarily, he has a comorbid learning problem along with ADHD. So this child was in the balcony of the 4th floor, and he tried to, he wanted, there were some flowering pots kept in the balcony. So he liked the flower, and there was a butterfly sitting on that flower. He wanted to pluck or catch the butterfly, and he almost bent 3/4 half his body out of the balcony. He was about to fall up, and the parents grabbed him. And that was, and despite there were repeated complaints from the teacher earlier that he was not sit in this place, but this thing that, he was about to jump out of the balcony, that kind of raised a red flag in the parents' mind, and they approached me for his issues. So inattention, as I said, again, mostly missed because this is taken as a dreamy child. So as I said, that ADHD and for that matter, all neurodevelopmental conditions do not come alone. They always go in groups together, or they move around in groups. So what is the commonest comorbidity is oppositional defiant behavior. Oppositional defiant means do not follow rules, and they can have conduct like problems. So they may have because of their impulsivity, they may have they are more prone for lying. They're very fond of fires. So they take a matchbox and they'll just lit up a fire, or they're very cruel to animals, etc. Right? 5 times depression is more common. These are internalizing problems, and this usually comes in the late adolescence and early adulthood. Anxiety again is very common, especially in ADHD in girls. Anxiety and depression is more common, whereas in boys, it is oppositional defiant behavior and disorder conduct problems, which are more common. So again, a revision, as I said, 3 types of ADHD. The HI one is more in the preschool age group. The combined one is the commonest, that is hyperactivity and inattention. And the inattentive one is more common in girls. So how does one evaluate for ADHD? Basics are always first. The foundation is the history. And in the history, we will focus on the developmental history to know whether the ADHD is acute, whether it is intermittent, whether it is episodic, or whether it has come before the age of 4 years or after the age of 4 years. So the DSM criteria mentions very clearly that the onset of ADHD has to be between the ages 4 to 12 years for a diagnosis for ADHD. So examination is more of observation, observing the child in the clinic, observing repeated observations in a clinic. And that is why the evaluation for ADHD, or for that matter, any neurodevelopmental condition, is not your regular 5-10 minutes kind of a job. It takes almost half an hour to 45 minutes each session to have the history and the examination, and to build a rapport with the parents and the child for them to come out with the other important clues on the history. So we do the observation of the child, uh, either in person solo or with the parent, and do assessment and investigation in forms of the tools that we will be discussing, primarily the Vanderbilt, to gather more information how the child is in different settings, 3 different settings, preferably at the school, to know his behavior in the classroom as well as the impact on the academics, in the home, how he's behaving when he's not in a control situation, okay, where he's in free time, and how is he doing unstructured play, or say how is he coping with himself when he's left to his own devices, how he's organizing himself. And in the community setting for our children would be in the playground or during tuitions or when they go to the relative's house, etc. So how do they behave there? We also look for any comorbidities, as we said, because they can also hamper the ultimate outcome and the prognosis. So there are one should know that there are 2 types of ADHD. One is the simple and the complex. The simple ADHD, though it is simple, is not so simple in terms of the prevalence. Only 25 to 40% of ADHDs are simple type. When do we call them simple ADHD? When there is no comorbid condition. And we saw in the previous slides that comorbidity is usually a norm. It is about 10 to 15 times higher in our study that I showed you all previously. In the community, in ADHD, the prevalence is almost, comorbidity is almost 70% of the ADHD population. So when you have no comorbidity, when the ages are between 4 to 12 years of age, when the response to treatment is optimal and it impacts only mildly to moderate the functioning in all these 3 domains of the community, the home, or the school, then we call it as simple. Usually, as a norm, it is complex type of ADHD that is more common. So to the step 1, we are treating the history. So history is, we need to build a rapport with both the child and the family. And believe me, building a rapport with the child is a very difficult task because they are very sharp, they're quick to grasp, and they also know that, their behavior is not what is expected. And so they are not very, especially the adolescents, when they come to the clinic, to my clinic, they see the autism kids, etc., and they are sitting with them. They are like a little embarrassed that why am I being here? They know that they need to be here, but they're not very open about it. So building a rapport takes a lot of time, and it is important to build a rapport with the child and family also, to know whether there is a parental component of ADHD present, what are the environmental stresses in the family, which may not come out during the first visit. It usually evolves gradually. I would like to interview the child and the parent together, because the child often, should know what the parent is talking, giving in the history. And it also helps us in cues in building it up when we are interviewing the child separately. So I like to interview both of them together, and then the parent waits outside, and then the child comes in. And after that, the child goes out, and then the parent comes in. So that is why, as I said, it takes a good 45 minutes, multiple sessions when we are seeing neurodevelopmental condition. What I generally begin with is asking for what are the likes of the child. So instead of beginning in a very accusatory tone, अरे तुमको पढ़ाई में इंटरेस्ट है क्या, या तुम बहुत उछल कूद कर रहे हो, ऐसे मम्मी बोल रही है. I just talk very nonchalantly. What does he like? What are the hobbies? What are his interests? And if it is a preschooler or a young child, usually give them crayons or coloring. So that way they get a little more relaxed or more open to a history taking. Then understanding the concerns from the parent or even the child, the young adolescent will also tell you that quite a few, as I told you, are aware that there is something wrong with them, but they don't know, they don't have the words, or they don't know really what is wrong. They know that something is amiss. And when you give them the words, they realize, "Arey, haan, ye mere saath bhi aise hi hota hai." So what are the concerns for the child? What are concerns of the family, from the school, in the playground, etc., is what we ask in the history. And as a doctor, it is important to know what is the birth history, because they can give cues and clues to diagnosis. So we know that premature children, low birth weight children, children born of breech deliveries are more prone to ADHD. Children with a medical problem, either especially a neurological problem or an epilepsy problem, can have ADHD. So I see a lot of children with epilepsy with ADHD. Now, whether the epilepsy is because, whether the ADHD is because of the epilepsy per se, or the medicine per se, or an independent thing, is too difficult to know in these conditions. And in these children, I prefer not giving them anti-seizure medications, which can enhance or exaggerate their ADHD symptoms. Sleep is very important to know the hours of sleep and whether good sleep hygiene is maintained. Diet and nutrition, of course, is very important to know. So, we had whether the child is on sugar, a lot of sugar foods and sweetened foods and processed foods. And this typically after eating sugar, we get that sugar rush. So, is he eating chocolates a lot and then he's having the ADHD kind of symptoms? It's important to know the factors. Then coming on to the behavioral history, we ask for what are the challenging behaviors of the child. Is there any history of bullying? So that could be an aggravating environmental factor there. And what is the disciplining style of the parents? What is the academic history of the child, and whether he's struggling in any subjects, etc., or he's finding any difficulty with the academics? What is the interaction with the peers and the teacher? When we interview the child, we can do a casual, start with a casual conversation, and later on build up to more structured interview. And the structured interview, we can use heads. Head stands for home, employment, education, addictions, and whether there are suicide issues or suicidal tendencies, and what are the safety concerns of the child. So all these things can be asked for. We observe the child multiple sessions and do a detailed systemic examination and a general examination and an academic assessment also. Now coming to the DSM-5 criteria, first we'll discuss this before we look at the Vanderbilt tool. As I said, that the Vanderbilt tool and the Inclin tool is based on the DSM criteria. So the DSM gives, there are A, B, C, D, E criteria, that is 5 things the DSM mentions. What is important is in the A, the core symptoms of ADHD are given. It is divided in 2 parts, A1 and A2. A1 is for symptoms of inattention, and A2 is for symptoms of HI or the hyperactivity component. And if there are about 9 symptoms given, and out of 9, if the child has 6 symptoms present, then we say that if it is 6 out of 9 in A1, then we say that the child has inattention. If there are 6 out of 9 in H1 or the A2 criteria, then we say the child has HI. If between A1 and A2, total of 12 out of 18 criteria are present, then we say that the ADHD combined type is present. And in older children who are more than 16 years of age, it is not 6 out of 9, but it is 5 out of 9, which is the cutoff for diagnosis of ADHD. So this is the important part of the DSM. A, 4 symptoms. B is the age of onset. As I told previously also, the age of onset should be between 4 to 12 years of age. Then the pervasiveness of symptoms. This is very important. And we know this from the history, because we want to know whether the symptoms are present only in the school. So it is something in the school environment which is causing the child to behave in this particular manner. Is it at the home? Is it at the playground, or only at the daycare? So these symptoms have to be present in 3 different settings, at least 2 out of 3 different settings. So at home, at school, and in the community, what is the impact on the functioning? So the child could be ADHD, and we know in my medical class also, I can now say with confidence at least 3 to 4 of my classmates were ADHD, but were they on medications? No. So what is the impact of functioning one should gauge? Is the academic suffering? Is the behavior causing a suffering in the relationships, in the peer relationships? Or, is it hampering his or her personal potential to execute or be something in life beyond that? Is that ADHD coming in the way? So if the impact is moderate to severe, only then I would say one needs to treat it. And of course, E is by exclusion. So taking out the ADHD mimics, which we discussed previously. So going to the DSM-5 criteria very briefly, what are these 9 ones? For A1, A1, as I said, is for inattention. So the child doesn't give close attention, makes careless mistakes, doesn't hold the attention, is not maintained for not only in school work, but also in play or different activities. So even in leisure as well as in academics, doesn't seem to listen, fails to finish school work, and not only school work, but even little chores which are giving at home, has trouble organizing task activity, doesn't do or reluctant to do any sustained mental effort. So able to maintain attention in the minor cases, but not able to maintain attention, sustained mental attention. Then loses things often, is often distracted by external stimulus or external environmental factors, is forgetful in daily activities. So any 6 out of 9 would say that the child has A1 positive criteria. That means the child probably has ADD. Now A2, the child often fidgets, leaves the seat perennially in the classroom, is running around, jumping, always on the go, not able to play or get engaged in leisure activities quietly, like six out of 9 in A2, probably inattentive type, and 6 out of 9 in A2, but not in A1, then probably the HI type. So why tools are necessary? Why are Vanderbilt tools or say DSM-5 criteria necessary? Because it helps parents to identify and it helps them to score symptoms. As I said previously, the 20% of your parents would be having ADHD symptoms. So they also, when they are scoring, they realize, "Arey, main bhi aisa hi tha, or mujhe bhi aise hi ho raha." And sometimes I have a diet now, like the mom has got this adolescent young child uh, who has ADHD symptoms, who's under my treatment, and the father also came to me uh, to say that he is always had ADHD symptoms in childhood, and I referred him to the adult psychiatrist, and the father is also put on medications for the same. So it also helps to know that we are paying heed to what the school has to say, because invariably these children have symptoms or in the school, and there are complaints from the school, so we can get more information just to build up our case that yes, there is a definite impact. We know that there is an impact on the functioning of the child, and because there is a follow-up tool to Vanderbilt, one can use to monitor the results of your treatment. Because as I said, in neurodevelopmental condition, there are no biomarkers. So for say you have a child with diabetes, would be put on insulin, and the sugar would be used to monitor with the dose of insulin. So rather we chase the sugars to increase or decrease the dose of insulin. But in neurodevelopmental condition, there is unfortunately nothing like this. So the way to go about is doing baseline tools, putting them on medication, doing therapy, and monitoring them every quarterly. So as I said, there are the ADHD based screening tools are based on the DSM criteria. We give the parent or any other caregiver and teacher questionnaires. We look at information across different settings. We look at the objective is to put things in perspective. We score them. So it is a definitive visual score, not only to the parents, but also the child. And we use self-reporting scales for adolescents and adults. This is the Vanderbilt, a little more detail about the diagnostic Vanderbilt parent rating scale. It is a 55 items are there, and it takes about 10 minutes to score. 18 criteria, 9 plus 9 for inattention and hyperactivity is there. But in addition, how the 55 items has come, because 8 items are for oppositional defiant disorder. Remember, I talked about the comorbidities. So the Vanderbilt measures comorbidities also. 12 items are for conduct problems. 7 items are for anxiety and depression. So the Vanderbilt questionnaire has an assessment and follow-up questionnaire. It checks for the comorbidities. It takes information from the teacher, the parents. It has a performance scale, and a follow-up one also looks out for the medicine side effects. So this is how the Vanderbilt diagnostic parent rating scale will be. And look at the instruction. Each question, how often it applies to you, to your child, whether it is occasional, never, often, very often. And in the questionnaire for the teacher, it would be given that a teacher who has known this child for at least a minimum of 6 months or 3 months should be rating this questionnaire. So this is how the questionnaire look. Up to here, it is for inattentive feature. Up to here, it is for your hyperactivity features. From 19 onwards, it is more for comorbidities. Then one looks for argues with adults. So oppositionality, conduct problems, and this fearful, nervous, etc. So anxiety and depression kind of features. Also, importantly, it looks at the functioning. So again, look at it in academic functioning, reading, writing, maths, peer relationship. How does your child get along with your brothers, sisters, and with you and with others? Whether there's a problem, etc. And how does your child do in activities or team play? So this is how the scoring is. The scoring is very well given. So again, the teacher diagnostic, in that you have 43 questions, 18 of the DSM-5, that is the inattentive and the hyperactivity, and the rest of the symptoms are for the comorbidities. Right. So these are performance-based questions, and again, performance in their school, and the behavior in the classroom and for assignment completed. And the name of the teacher completes this form, right? So how does one go about establishing a diagnosis? Confirm. Once we get the questionnaire, we see, and we always confirm it using the DSM-5. So if there is a discrepancy, so again, as I spoke to you of having this preschooler girl with ADHD, with a lot of emotional dysregulation coming to me, when it was the child is in the face very much ADHD, jumping around, always on the go. But when I have given the Vanderbilt to the parent, they have underscored it, and she's not coming ADHD, because these are some of the parents are literate and well educated, so they Google and find out, and immediately they hook on and they think that the child will be put on medicine, so they tend to underscore it. So if your diagnosis, so as for everything, the physician diagnosis is always considered prime. So clinically, by observation, if you feel she fits in the DSM-5 criteria, which you will give to the parent and to the child, and it fits in the DSM-5 criteria for ADHD, then that diagnosis is more valid versus the screening Vanderbilt tool. As I said, the symptoms have to be present over 6 months. It has to be in 2 or more settings and should be present below the age of 12 years. So this is like a brief algorithm. When you have a child coming with inattention of hyperactivity or impulsivity symptoms, you rule out any other medical conditions which can mimic it, any other psychological condition which can mimic it, then significant environmental factors, trauma, etc., or it is neurodevelopmental condition itself. Is it autism, or is it a hearing problem or sensory problem? And can these symptoms be explained because of this condition, or are they coexisting present? We look at whether the DSM-5 criteria is satisfied, what type of the ADHD it is, whether any comorbidities, and what is the severity. So the conclusion side is that ADHD is not simple, and we need to have a detailed history. Assessment is most important for the diagnosis. We can use tools to elicit information which will help us in the diagnosis. Confirmation of diagnosis is always by the DSM-5. We look at comorbidities because they are present in almost 60 to 70% of the children. And we also like to know whether it's simple or complex ADHD because it will help us with our management. I think that is my last slide. If there are any questions, Kuntala?
Yes, ma'am. Yes, ma'am.
Yeah.
Thank you very much, ma'am, for very informative ADHD lecture. There is a question from Nilanjan Muzumdar. He is asking, how do we diagnose ADHD in adults? Is there anything criteria?
Yeah, so as I said, it is the DSM-5 criteria for the diagnosis, and one can use that for the adult ADHD also. And for self-reporting or questionnaire, screening questionnaire, there is a WHO autism ADHD self-reporting screening form, which is available on the internet, and which essentially are symptoms based on ADHD, and the adult has to screen for it. If it is, again, it is out of 9. If the questions 6 are present, then the likelihood of that part of ADHD is more present.
Yes, ma'am. Thank you very much, ma'am. So this was the only question we have.
Okay. There is
thank you very much, Dr.MonaGajre.
Yeah.
And thank you very much for the third edition of Brainmantra. It was indeed a learning experience and an enriching experience for all the clinicians who are there here. And we look forward, as we look forward to the fourth edition of Brainmantra in the next coming week. I take this opportunity to wish you and all the clinicians who are there here on the platform a very happy Diwali.
Thank you. Thank you. Happy Diwali to everyone.
Thank you very much, ma'am.
Happy Diwali. Thank you, ma'am.
Yeah, good night.
Thank you, ma'am. Good night.
Yeah.